As you can see, this is S1, this is L5, and this is L4. So we'll start with L4. So using the pointer, we acquire the entry point and the optimal trajectory. And using the ruler, you can also see how long the screw has to be and the width of the screw.
I started using navigation already back in 2012 or 2013, while I was still working at the Department of Neurosurgery at the University of Bonn. Here in Bethel, we use it since 2016.
The indications we treat using spinal navigation are from simple to complex instrumentation cases, from cervical to lumbar spine, including degenerative disease, trauma, tumor, and infections.
This case involves an 82-year-old patient with back pain and claudication symptoms not responding to conservative treatment. MRI, X-ray and CT images show mobile spondylolisthesis L4-5 with relevant stenosis. The patient is placed in a prone position with the feet facing the infrared camera. Drapes are wrapped tightly under the operating table and around the patient to allow the use of the C-arm without compromising sterility. By pointing the calibration matrix and a drill guide in the direction of the infrared camera, the instrument application starts automatically. Calibration is then performed by inserting the drill guide. With the help of a single X-ray shot, the surgeon palpates to find the level on which the patient reference array will be attached. A midline incision of 2 cm with incisions of the muscle fascia on both sides enable fixation of the patient reference array to the L5 spinous process. The C-arm is draped and a sterilizable tracking array is mounted on the side facing the infrared camera. The C-arm is then moved into position to obtain an intraoperative 3D scan. To protect the surgical team from radiation exposure, the C-arm is activated with a foot pedal from outside the room. The acquired images are automatically transferred to the navigation system and instantly registered to the patient. The C-arm can be moved away to allow access to the surgical side and navigation monitor. Registration accuracy is verified with a pointer on the spinous process and the patient reference array. Before making any additional incisions, the surgeon can plan the entry points and optimal trajectories for each screw using navigation. A ruler tool helps the surgeon determine the diameter and length of the screw to be used. A small 1.5 cm incision is made along the chosen entry point with deep incision of the muscle tissue. This facilitates the entry of the drill guide and the approach towards the preferred anchor point on the bone surface. Once the optimal trajectory is determined, a drill is inserted through the guide to drill the pilot hole. The depth control can be adjusted to precisely define the maximal depth. The drill is removed and a K-wire is inserted through the drill guide. The drill guide is removed and the first cannulated screw is inserted over the K-wire and guided towards the pilot hole. After the screw is firmly in place, the K-wire can be removed. These steps are repeated for the remaining screws. To verify the correct placement of the screws, AP and lateral shots are taken. Navigation is used once more to determine access to the disc space without any additional radiation. The clamp can then be taken off to begin with the removal and replacement of the disc. A microscope is used for the lateral preparation of the muscle and proper exposure of the interlaminar space and facet joint. The lamina and joint are partially removed in order to properly access the disc. An incision is made in the posterior longitudinal ligament and the disc is removed. A cage is placed in the cavity where the disc was removed, followed by 2 rods, which will be fixed to the screws and hold everything in place. A final scan can be performed to verify the correct placement of screws, rod and cage. The incisions can then be stitched back together to complete the surgery.